Hello guys, welcome to our Sureshot series. Today we are going to discuss about the ECG part 1. In this we are going to include the basics of the ECG, Bradyarrhythmias and the Tachyarrhythmias and their treatment protocol. So before we start the video, please do subscribe and share with your friends. So let's start about the basics of the ECG. So when I say basics of the ECG, we have to know about the action potential of the atrium and the ventricle. So we all know heart is a four-chambered heart. In this, we have the two atrium and the two ventricles. So the ventricles will be having the more muscular myocardial cells comparing to the atrium. So how this electrical activity is generated? Usually your atrium will be at the minus 80 millivolts. So this is the polarized state of the atrium. So at this point, there is a sodium influx. Immediately, there will be a sodium influx, which will be increasing the depolarized state, means the contraction of the heart will be occurring here. So immediately after, there will be a potassium efflux. So this will be causing the repolarization of the heart. And more potassium efflux will be seen. So the potassium is going out. So this will be causing the myocardial cell. Inside the myocardial cells, there will be a most negative side of the cell will be generated. So this is how the depolarization and the repolarization seen in the atrium. But most prominently, when we monitor the atrium, there will be only three phases, guys. What are those three phases? The fourth phase and the zero phase. This is your the zero phase, and also this is the your third phase. So there will be a sodium influx, immediately the depolarization, and after that efflux of the potassium, which will be causing the repolarization and back to the polarized state of the atrium. So, but comparing to the ventricle, we already discussed ventricle is the most muscular tissue. So that's why it will be having the different phases, and it will also having the flat phases. Well, let's discuss the ventricle. So same like that, there is a minus 85 millivolts of the polarized state of the resting potential of the ventricle. So this will cause the sudden influx of the sodium. So sodium will cause the depolarization or the contraction of the ventricles. So at this point, this is your first phase, guys. In this first phase, there is a potassium out. Okay, the potassium efflux is seen. So the potassium efflux will be causing the repolarization state, right? So there is a still potassium is going to go out, but at this point there is a inside of the calcium. So the calcium efflux, so the calcium will be influx of the ventricles. So the polarization state will be maintained here. So even though the positive ions is going out, the positive ions is coming inside. So this will be maintaining the plateau phase. This is your second phase of the action potential in the ventricles. And after that, immediately the calcium channels will be closed here. So the calcium channels are going to closed here. So still there will be a potassium channels are open, and the more and more potassium channels are open and released outside of the cell, causing the repolarization of the ventricle. So this is your fourth phase. This is your, I'm sorry, this is your zero phase. This is your fourth phase. This is your zero phase, and this is your first phase, and this is your second and third, and again here your fourth phase. So this is how the ventricles action potential and the atrium action potential will be maintained. So next, moving on to the next step, how is the electrical activity or the conduction pathway of the heart is maintained? Here you can see this is the pacemaker of the heart. Why we call the pacemaker of the heart, guys? Because the electrical activity is generated from the SA node only. So when the SA node is start the electrical activity, when it starts shooting from the SA node, it will be transmitted to your AV node. So here it will be transmitted to your AV node, and after the AV node, through the bundle of his, the more and more electrical activity will be reached to the ventricle side. And from the bundle of his, it will be divided into the right bundle branch and the left bundle branch. Here you can see this is your right bundle branch and this is your left bundle branch. And from the bundle branches, there is a Purkinje fibers, and this will be transmitted to entire muscular tissue of the cardiac muscle. So this is how the entire conduction of the pathway is seen in the heart. So let's revise once again. From the SA node, it will be transmitted to the AV node, and from the AV node, it will be transmitted to the bundle of His. Through the bundle of His, it is divided into the right bundle branch and the left bundle branch. And from the bundle branches, there will be a Purkinje fibers, and Purkinje fibers will be transmitted to entire muscular tissue of the heart. So this is how the entire electrical activity is generated and maintained throughout our life cycle. So let's see how these ECG waves are generated. So we all know that electrical activity is going on in our heart, but how can we transmit that into the graphical presentation of the ECG thing? So let's start from here. So how the P wave is generated? What is the significance of the P wave, guys? So the P waves, as we discussed, it is generated from the SA node, right? So SA node is the P pacemaker of the heart. SA node should be started. So the P wave is generated when the SA node is transmitting its signals to the AV node. So here you can see the SA node is generated when there is a atrial contraction and the SA node transmission of the electrical activity to the AV node. And from the AV node, here you can see there is a delay in the AV node. So this isoelectrical line is due to delay in the AV node. So this is by the isoelectrical line. So there is no activity seen in this line. So this is due to AV node contraction of the heart. Okay, this is your P wave. And after that, here through the AV node, this will be transmitted to the bundle of his to the both right bundle branch and the left bundle branch. So that's why we are going to see the QRS complex. This is your complete QRS complex is due to what, guys? This is due to the ventricle contraction or the ventricle depolarization. Okay, this is your ventricle depolarization. And immediately after that, so there will be a slight movement of the, there is a steady movement, all the polarized state, all the cells are in the depolarized state. That means the positive charge inside the cells, which will be causing the, again, no waves is seen. This is the polarized state. Okay, this is the polarized state. And immediately after, there is a relaxation of the entire muscle cells, like ventricles are all going to shoot back and send it back to the repolarization state. This will cause the P. So this is your ventricular repolarization. So this is how the ECG is formed, guys. So next, moving on to the, what are the ECG waves, complexes, intervals, and the segments. So we all know that there is a P wave and the QRS complex and the T wave. So what are these? Usually, we all know that P wave is the atrial depolarization, right? Atrial depolarization. And next, QRS complex is your ventricle depolarization. And your T wave is the ventricle repolarization. So nothing but the depolarization is the contraction, repolarization is the relaxation. So these are the waves, P, Q, R, S, T waves. These are the four waves that we have. And also we have the intervals and the segments. So what are the segments and what are the intervals? So first thing that we have to remember is the segments, whichever the segments that does not include the waves. Okay, but intervals will include the waves and the segments. Waves plus segments is your intervals, but segments are only waves. Okay, here you can see what are the segments, guys. The segments are your PR segment and the ST segment. These are the only two segments that will be present in the entire ECG. This will not include the intervals, but this will include the waves. And these both are your isoelectrical lines. One is your AV delay and another one is the polarized state of the ventricles. So what are the intervals then? So your intervals include the PR interval, QT interval, and the TP interval, and also your RR interval. So these are the four intervals that will be presented: PR interval, QT interval, and TP interval, and the RR intervals. These are the four intervals that is present in the ECG. So next, moving on to the, what are the leads? First, we have to discuss the what are the leads and how to get the ECG representation from this. So we have the 12 lead ECG. Okay, in the 12 lead ECG, it is divided into the unipolar, and another one is the divided into the bipolar of the leads. And also there are the other types of, so sometimes we will be listening to the vertical leads. Okay, sometimes we will be listening to the vertical leads, horizontal leads. So this is also part of this classification only. What are the unipolar leads? When I say unipolar leads, these are your two types. One is your augmented leads and another one is your precordial leads. Okay, Augmented leads your AVF, okay, and your AVR and AVL. So these are your augmented unipolar leads. And next you have your bipolar leads. What are those bipolar leads, guys? Lead 1, lead 2, and the lead 3. Precordial leads your V1 to V6. Sometimes V7, V8, and V9 also include because the posterior side of the heart is included. And what are the vertical and the horizontal? Horizontal means these are your precordial leads, nothing but the V1 to V6, the position of the leads. Vertical is your both lead 1, lead 2, lead 3, and also your AV, augmented leads, AVR, AVF, and the AVL. So these are the other leads, vertical and the horizontal. This is the entire 12 lead of the ECG. So in the beginning of the ECG development or the discovery, so there is this specific triangle that is designed by the our four ancestors of the ECG scientists. They discovered that there is a Einthoven triangle. Okay, Einthoven triangle. What he is trying to say is the lead 1 plus lead 3 is equal to lead 2. So when there is a formation of the lead 1 plus the lead 3 is equal to the lead 2. That is what he said. How he presented that means when there is an electrical activity from the right side of the heart to the left side towards the positive side, and the lead 3 from the left side of the heart towards to the inferior side of the heart is lead 3. So when we combine this both two, there will be a solution for the lead 2. This is what the Einthoven triangle represents. And after the discovery of the Einthoven triangle, we also got the Goldberger discovery. Goldberger said that instead of going towards the lead 1, 2, 3, we can also get the activity from the bipolar leads, from the augmented leads from your right side of the heart and also left side of the heart and also inferior side of the heart. So he said AVR, AVL, and the AVF. These are your Goldberger leads. Next, so this is the precordial leads, right? This is your chest leads. Okay, precordial are the chest leads. And horizontally, when we look at the entire side of the heart from the anterior, septal, posterior, and the lateral side, all these sides. So this is going to represent the chest leads of the precordial leads. And after that, Einthoven triangle and the Goldberger triangle, when we mix together, here you can see the lead 1 and lead 3, which will be concluding your lead 2. And the Goldberger leads, here you can see AVL, AVF, and the AVR. So this is how the both the entire, we are just picturing the camera. So entire, we are placing the camera towards the entire around the heart, and we are looking for the where is the electrical activity and how the electrical activity is generated in the heart. So here you can see this is the normal picture of the heart ECG and the proper electrical activity. So this is the lead 2 where we can see the P waves, the sinus rhythm of the heart, and this will be showing your what is the proper electrical activity is going on. In the proper electrical activity, what that means, guys? So that means that the patient should be having the all waves. Okay, P, Q, R, S, T. This wave should be seen. So there will be no ST elevation. There will be no QT prolongation. There will be a short, no PR segment or no PR interval. So all this should be maintained in the normal ECG. So usually the normal speed of the ECG is 25 mm per second. Okay, this is the universally we use the 25 mm per second is the speed of the ECG. And in this, we are going to see the each and every wave segment and prolongation, ST segment elevation or the depression. All this we are going to check when the patient is presented with the heart complaints. But how to calculate these segments and their seconds and their presentation? Usually when the small box of the ECG, here you can see this is the small box, right? And the small box will be 0.04 seconds. Okay, this is 0.04 seconds. And when I calculate this entire box, when I calculate this entire big box, it is around 0.2 seconds. Okay, and when I calculate the small box in the sense of the length, that will be 1 mm, and the amplitude is the 0.1 mm. And whatever the amplitude of the big box, that is around 0.5 mm, right? This is how the the small box and the big box will be calculated. And we can specifically, if we calculate the P wave, what is the P wave gets? Atrial depolarization. What is the morphology of the P wave? It is usually upright. That means like this, it will be upright in the lead 2 and biphasic. The biphasic means like this. So there will be upward stroke and also the downward stroke. The biphasic in the V1. This is also asked question in your previous examination. And amplitude is less than 2.5 mm. So this is the amplitude of the normal P wave is seen. What is the duration? So as we discussed, the 0.04 seconds is the one small box and entire P wave will be less than 0.12 seconds. So that means 3 small boxes of the ECG wave is the P wave. So, but what are the pathologies behind the P wave gets? When there is an absent P wave, this is your atrial fibrillation. What we discussed, the SA node is going to transmit the signals. If the SA node is not stopping, that means the heart is having the something conduction pathway disorders. So that is your atrial fibrillation. And the sawtooth waves, what is the sawtooth waves? Like this. These are the sawtooth waves. This is seen in the atrial flutter. And the peaked P waves like this will be seen. This is usually presented in the right atrial enlargement patients like COPD or other pulmonology conditions like P pulmonale, the pulmonary hypertension with the also patients suffering from the pulmonary pathology, other disease that will be showing the P wave as a very elevated or the tall peaked P waves is seen. Next, notch or the bifid. So notch or the bifid like this it will be presented. This is seen in the left atrial enlargement. Usually the pathology for the glandular heart diseases. Best example is the mitral stenosis. And the inverted P waves, usually this is rarely presented, like inverted P waves will be presented like this. This is due to ectopic atrial rhythms or the junctional rhythm. The sudden ectopic atrial rhythms will be presented like this. Next, moving on to the PR interval and the AV node conduction time. So we all discussed it, right? The segment is a isoelectrical line. So the PR interval is going to include your P wave and also the PR segment. So what is the normal duration of this? This is also the 3 to 5 small boxes. It means 0.04 into the 3 or the 5. That means it is less than 0.20 seconds only. Where this is presented, if the PR interval, if this is prolonged, usually seen in your heart blocks. The Mobitz type 1, Mobitz type 2 or the complete heart block, you will be seeing the AV blocks. And the PR is less than 12 seconds. If the PR is less than 12 seconds, so that is usually presented in the shortened PR interval like Wolff-Parkinson-White syndrome or the Loewen-Gongong-Levine syndrome. These are the 2 other conditions. In this, there is an accessory pathway. Other than what we discussed, the SA node, AV node pathway, there will be the other pathway, electrical activity is coming. That's why PR interval is shortened. So let's discuss how to calculate the normal and the abnormal heart rate. When we say the regular heart rate, that means your normal heart rate. What is the normal heart rate, guys? It is between the 60 to 120 beats per minute. So this is the normal heart rate according to the Harrison's. So how the regular heart rate will be presented? All the P wave, Q wave, RST waves is presented. PR interval is normal within the limits. QT interval is not within the limits, and there is no P wave absence, and everything is the presented in the within the time limit and the normal presentation only. When we say the regular heart rate, usually presented in the WPV syndrome, or it is presented in your conditions like atrial fibrillation, also presented in your heart blocks. This is the irregular heartbeat. But how to calculate the heart rate and the rhythm? You can calculate in the 2 ways. One is the, you can calculate by the 300 divided by the big squares. Okay, these big squares will be calculated between the RR intervals. So this is the one type of method. You can calculate the regular heart rate 300 divided by the big squares. And another one calculation is the 1500 divided by the small squares within the same again your RR intervals. And there is the other methods also. This is for your regular heart rate. When there is a regular heart rate and all the interval segments is within the time limits, you can calculate by the 300 and the 1500 methods. What about irregular heart rate? For the irregular heart rate, we have the other formulas. For example, when there is an irregular heart rate, you have to take the 30 large boxes. Take the 30 large boxes and divided into the 10. And 30 large boxes should be from the number of 30 large boxes in the QRS complexes. Okay. And how to calculate the irregular heart rate? In the irregular heart rate, there is a two formulas. One is number of QRS complexes. Number of QRS complexes in the 30 large boxes multiply by 10. So this is the one formula, and another formula is the again number of QRS complexes. This is only the 15 large boxes into 20. So this is how you can calculate the irregular heart rate also. So let's discuss the axis deviation. Usually always remember when there is an axis deviation question is given, so there are multiple formulas that we can use. But in the examination, we can't remember and calculate the entire this method. Instead of that, you have to take the in the ECG lead 1 and the lead AVF. Remember your lead 1 is the right hand thumb and the lead AVF is the left hand thumb. If the both thumbs are in the positive side, that means it is the normal axis deviation. If the both thumbs in the negative side, then it is the extreme axis deviation. What is this axis deviation? So your heart is tilts towards that side. So the ECG, all the waves is electrical activity is not going in the same side of the pathway that we discussed beginning. Instead, it is going on the different side of the pathway. And if the your right side is in the positive side, and if it is your left side is in the negative side, that means it is a left axis deviation. And your right thumb is in the negative side and the left thumb is the positive side, then it is the right axis deviation. So this is how you can calculate the axis deviation. Here you can see the minus 32 plus 100. This is your normal axis deviation. And remaining all values also should be remembered. Next, moving on to the classification of the Bradyarrhythmias and the Tachyarrhythmias. In the Bradyarrhythmias, we have only three. One is your sinus bradycardia, and the other one is a sick sinus syndrome and the heart blocks. Only these three are present. So sinus bradycardia usually present in the athletes and also the patients like fever, okay, and febrile illnesses also present with the sinus bradycardia. What is the treatment? Just supportive treatment only. When the patient is having the not significant bradycardia, we can continue as a supportive, treat the underlying cause. But if the patient is having the severe bradycardia, then you have to give the IV atropine. Okay. And how to find out the sinus bradycardia? Remember, in the sinus bradycardia, every wave is presented. So the P wave and the QRS and the T is presented. And there is PR interval is also normal. So this is how the sinus bradycardia is presented. So the interval between the each and every electrical activity is slow, but waves and the intervals will be normal only. Next, moving on to the sick sinus syndrome. Sick sinus syndrome usually in the pathologies like the endocrinopathies. Okay, in the endocrino pathologies, this will be presented. And how this is presented, guys? Most of the sick sinus syndromes will be tachy and the brady. Okay, suddenly there will be a heart rate is raising and suddenly heart rate is decreasing. So this is how the sick sinus syndrome will be presented. And how to control? Simply give the beta blockers when there is a high chance of the tachy and stop the beta blockers if there is a bradycardia, or treat the underlying cause. So this is how we can treat this patient. And never start the beta blockers on the patient presenting with the slow heart rate, and never continue the complete beta blockers course of the treatment in the sick sinus syndrome. Next, moving on to the heart blocks. And how the heart blocks? There are the four types of the heart blocks. The first degree heart block, the P wave is presented, but the PR interval is prolonged. Okay, over the time, the PR interval will be prolonged. Here you can see the PR interval will be prolonged. So this is how the first degree heart block is presented. And what is the treatment? The treatment is supportive only. Treat the underlying cause. Next, moving on to the second degree heart block. This is your Mobitz type 1 or the Venke back type. In the Mobitz type 1 or the Venke back, what happening, guys? Here the PR interval will be prolonged. Okay, so the PR interval will be prolonged. So the interval will be increasing. Suddenly there is a drop of the QRS complex. Okay, so the sudden drop of the QRS complex is presented in the second degree heart block. And next, moving on to the Mobitz type 2 and the second degree heart block, what happens here? Your PR interval is normal. Okay, what we discussed in the previous one, here you can see the first degree heart block, the PR interval is prolonged. Okay, and in the second degree Mobitz type 1, the PR interval is prolonged and the QRS drop, sudden drop of the QRS complex. But in the second degree, the Mobitz type 2, the PR interval is normal and there is a sudden drop of the QRS complex. So this is your second degree heart block and this is very serious condition. What we can do, this patient need the pacemaker. Okay, so this patient might be needing the pacemaker as a treatment. And complete third degree heart block. What is a complete third degree heart block? Your P wave and your QRS complex is completely dissociated. Okay, there is a dissociation between the both P wave and the QRS complex. The treatment is only available for this patient with the pacemaker. Why we need the pacemaker? Because your P wave and the QRS complex is not together. The SA node is not shooting properly. There is a dissociation between the AV node. So the entire electrical pathway is disturbed. So this patient must need the pacemaker. Next, moving on to the tachyarrhythmias. In the tachyarrhythmias, the classification is the based on the QRS complex. Okay. If the QRS complex is the more than 120 milliseconds, if the QRS complex is the less than 120 milliseconds, that means it's the wide QRS complex and it is the narrow QRS complex. Okay, in the wide QRS complex, we have the only two examples. That is your one is your ventricular fibrillation and another one is the ventricular tachycardia. In the narrow QRS complexes, it is subdivided into the there is a P waves. P waves is present and the P waves are absent. Okay, in the narrow QRS complexes, if the P waves is presented, usually that is present in your sinus tachycardia and your atrial tachycardia. And the atrial tachycardia, we have the sub-classification. One is your atrial flutter and another one is the monoatrial, multi-atrial tachycardia. Okay, this is also your part of your atrial tachycardia. And the V waves is absent, usually your atrial fibrillation and your paroxysmal supraventricular tachycardia. So this is what the tachyarrhythmias. So let's see each and every example. What is the difference between the sinus tachycardia and the atrial tachycardia? Remember that sinus tachycardia is the most common overall arrhythmia in the human beings, adults, kids, everywhere. So the most common arrhythmia, if it is asked, that is your sinus tachycardia. All right. And what is the difference between the sinus tachycardia and the atrial tachycardia? Both are belongs to the narrow QRS complex only, right? This is also belongs to the narrow QRS complex. And what is the narrow QRS complex? That means it is what less than 120 milliseconds. But what is the difference between the sinus tachycardia and the atrial tachycardia? So your sinus tachycardia, the P wave is equal to the QRS complex. Number of P waves is equal to the QRS complex. Whereas in your atrial tachycardia, more and more P waves is present. Okay, more and more P waves are presented. So this is what the atrial tachycardia. In the sinus tachycardia, it is the only pathology, that is the most common pathology. Whatever the patient is suffering from the fever, athletes, all these conditions will be presented with the sinus tachycardia only. So you have to treat the patient with the supportive treatment and treat the underlying cause. What about the atrial tachycardia patients? You have to find out whether it is the atrial flutter or it is the multi-atrial tachycardia. So what is this type of the atrial tachycardia? You have to treat and you have to treat the specific pathology of this condition. And what is the atrial fibrillation? Here in this ECG, you can see there is a QRS complex and there is a T wave, but there is no P wave. So the P wave is absent. When the P wave is absent, always remember that is your atrial fibrillation. In the atrial fibrillation, what happening? Your heart is shaking. There is no SA node itself activating. So there is a high chance that this patient can have the severe condition. What is the complication, guys? From the complication, there will be a clot formation. Okay, there will be a clot formation. If this clot can travel in the blood circulation, it can cause the emboli, it can cause the stroke, and even it can cause the glomerular nephritis, and multiple organ dysfunction will be seen with the atrial fibrillation. What is the treatment then? So if the patient, let's say that the patient is presented with the P wave absent atrial fibrillation, and the patient is having the less than 90 by 60. That means that the patient is hemodynamically unstable. Then you have to do the cardioversion. Okay, immediately you have to do the cardioversion for this patient. Let's say that the patient is normal, his vitals are stable. Then you can go for the treatment. What is the drug of the choice for this patient? That is the amiodarone. Okay, this is the drug of the choice. But how to prevent the stroke and emboli? There is a clot formation is already going on. Do the screening echo. Okay, do the screening echo in this patient. If there is a clot formation, start the patient on the dual antiplatelets. Okay, start the patient on the dual antiplatelets for the 21 days. And if the patient is not having the no clot, then you can continue with the amiodarone treatment. And remember that your atrial fibrillation is the most common sustained arrhythmia. So over the time also, like 2 months, 3 months also, this patient will be presented. This is the most sustained arrhythmia in the adults. So this is your atrial fibrillation. Next, moving on to the atrial flutter. This is also like more than 200 heart rate. The patient will be having the more than 200 heart rate. And the P wave, how the P wave is presented, guys, like a sine wave pattern. That's why it is also known as the sine wave pattern of the atrial flutter. So why these patients will be usually presented? Mostly atrial flutter, all the waves is presented, right? The P wave, Q wave are every the PQRS waves is presented, and the XT interval is normal, and also the patient PR interval is normal. What we can do for this patient is that when the patient is having the less than 90 by 60, patient is unstable, then you can go for the cardioversion. But if the patient is normal, the patient vitals are stable, then you can go for the beta blockers. Okay, you can give the beta blockers for this patient. Okay, that will be supportive treatment for this patient. Atrial flutter will be decreased, or you can also start the patient on the calcium channel blockers. So these are the only two treatments that we can give. Don't give the anti-arrhythmias. Don't give your amiodarone. Don't give your iglutide or the verapamil. Any other drugs you should not be giving. Only the treatment that we can follow is the beta blockers or the calcium channel blockers in the patient those who are stable. That is the treatment protocol for the atrial flutter. And next, moving on to the paroxysmal supraventricular tachycardia. Remember that your paroxysmal supraventricular tachycardia is a regular rhythm. This is the regular rhythm. Here you can see this is a very regular rhythm each and every interval. So that is what the paroxysmal supraventricular tachycardia is presented. And this is the most common arrhythmia is presented in the children. Whereas your most sustained arrhythmia is atrial fibrillation. Most common arrhythmia overall in the adults, that is your sinus tachycardia. In the children, this is the most common paroxysmal supraventricular tachycardia arrhythmia is present. And this is the regular rhythm. And what is the difference between the atrial fibrillation and the supraventricular tachycardia? It is regular and the P wave is absent. Same as this. This is also if the patient vitals are unstable, patient vitals are less than 90 by 60, patient cannot be survived, then you can give the immediately cardioversion. But let's say that the patient vitals are stable and patient can look at you and patient Glasgow Coma scale is also normal, then you can go for the IV, the rapid infusion of the drug. Okay, the rapid infusion of the drug. This is your adenosine. This is the only drug that we can use immediately. But if the examiner is asking you what is the drug of the choice for the supraventricular tachycardia, then you have to mark the adenosine. But he will be asking what is the first line of the therapy. Okay, what is the first line of the therapy? Then you have to mark the vagal maneuvers. Okay, vagal maneuvers is the first line of the treatment. But what is the drug of the choice? That is the adenosine. If the patient, those who are suffering from the asthma, remember that your adenosine is contraindicated. You should not give the adenosine. In this patient, what you can give? You can give the drug of the choice is the verapamil. Okay, verapamil can be given in this patient. So this is how the paroxysmal supraventricular tachycardia is treated. And next, moving on to the multifocal atrial tachycardia. What is a multifocal atrial tachycardia? It is a part of the atrial tachycardia. What is a specifically? This is seen in the patients those who are suffering from the COPD, or the patient is suffering from the theophylline. Remember this drug we use in the patients those who are suffering from the asthma. So in this patient, if there is a theophylline toxicity, then also we can see the multifocal atrial tachycardia. What is the specifically multifocal atrial tachycardia? So the P wave, whichever the P wave is present, but the P wave will be seen as a three different. So the morphology of the P wave is different in the 3 points. Here you can see the P wave is presented like this. Here you can see it is a bifid pathway, and here again it is the peak pathway. So the three different pathways are the morphology is presented in the P waves. That is your multifocal atrial tachycardia. If the patient is having the stables are again, the patient stables are deranged, go for the cardioversion immediately. But the patient is normal, the vitals are stable, then you can give the CCB or the beta blockers for this patient. So this is the treatment how we can give for this patient. All right. Next, moving on to the next one, that is your ventricular tachycardia. There is a monophasic one and the polyphasic one. What is the ventricular tachycardia, guys? Entire pathway here you can see the wide QRS complex. The QRS complex is wider, more than 120 milliseconds. You cannot identify where is the P waves, where is the QRS complex. So the morphology of the entire pathway is changed. So this is how the patients presented with the ventricular tachycardia. Ventricular tachycardia is treated differently, not like your other pathways. When we see the atrial arrhythmias, like your whatever arrhythmias is presented in the patients, those who are with the atrial fibrillation or the paroxysmal supraventricular tachycardia is treated differently, and ventricular tachycardia is treated differently. How? Because when there is a ventricular tachycardia, the major muscle of the heart is not getting the contraction or the electrical activity. So high chance that the patient can land into the death. Sudden cause of the death can be seen in this patient. But how to treat this patient? So if you see the patient presented with the VT with pulse, the pulse is presented, the patient is having the ventricular tachycardia, and the patient vitals are stable, then you can go for the amiodarone. Okay, amiodarone you can use for this patient. Let's say that the patient VT, the pulse is not present. Okay, vitals are not stable. Patient vitals are unstable. Then you have to go for the defibrillation. Okay, then you can go for the defibrillation. Let's say that the patient having the pulse is present. Okay, but the vitals are unstable. You can go for the cardioversion for this patient. So this is how the ventricular tachycardia is treated. Next, moving on to the ventricular fibrillation, there is a complete dissociation between the all the waves. Okay, all the interval segments all are disarranged. So high chance that this patient can land into the death, regardless whether the patient is stable, patient vitals are stable or unstable. We don't matter. We have to do the defibrillation for this patient. So this is the only treatment that is presented. That is the defibrillation for this patient. You have to do regardless of the patient presentation. And next, moving on to the torsitis depointers. How the torsitis depointers is presented? Mostly this is due to the QT prolongation. So the more and more QT prolongation, this will be causing into the torsitis depointers. If you see, this is a sine wave pattern that is presented in the torsitis depointers. What is the treatment of the choice for this patient? You have to do the IV 2 grams of MgS4. So this is the first line of the treatment for the torsitis depointers. And where the QT prolongation, mostly the QT prolongation is caused by which of the following? Remember A, B, C, D. Okay, A, B, C, D means your A means that the patient, those who are suffering from the arrhythmias, you are giving the anti-arrhythmic drugs like your class 1A or the class 1C or the class 3. These anti-arrhythmic drugs you are giving, this can trigger the QT prolongation. And you are giving the antibiotics. Okay, you are giving the antibiotics like macrolides, azithromycin, or you are giving the other drugs like your erythromycin, levofloxacin, bedaquinolone. All these drugs can cause this one. And also you are giving the patients psychotics. Okay, patients you are giving the psychotic drugs Okay, this is like a psychotic. Remember, like C for your psychotic drugs. And if you are giving the D drugs, what are these D drugs, guys? When you are giving this, like vomiting, okay, your domperidone, all these drugs can cause the, and also D for depressant drugs. This all can trigger the QT prolongation in the patients. Next, moving on to the Wolff-Parkinson-White-Heart syndrome. Wolff-Parkinson-White syndrome. What is this syndrome, guys? Specifically, what we discussed, your PR interval will be shortened. Okay, your PR interval will be shortened, and there is a delta wave. So here you can see there is a delta wave present is seen in the WPV syndrome. But why this pathway is occurring in here? Because the pathway, the normal pathway will be from the SA node to the AV node and from the AV node to the bundle branches. But what happening in the WPV syndrome? There is an accessory pathway. Here you can see there is an extra pathway that is going to trigger the, that is going to decrease the PR interval, and that is also causing the delta. So this is known as the bundle of Kent. This extra pathway is known as the bundle of Kent. It's supposed to be coming from the bundle of His. Instead of that accessory extra pathway, this is known as the bundle of Kent. What we can do? We have to do the radio ablation. Okay, we can do the radio ablation. Or the patient, those who are suffering from the severe WPV syndrome, then you can do the drugs like prokinamide. Okay, you can use your prokinamide or the flecainide. These drugs can be given in this patient. And what about the Long-Gong-Levine syndrome? The Long-Gong-Levine syndrome, yes, there is an accessory pathway. Here also there is an extra accessory pathway which will be causing the PR interval will be shortened. PR interval will be shortened, but there is no delta. So the only difference between the Long-Gong-Levine syndrome and the WPV syndrome is the delta wave is absent in the LGL syndrome and the delta wave is present in the WPV syndrome. And what is the treatment? The treatment is the supportive only. Just treat the underlying cause. Unlike this is a very severe condition, extra pathway, bundle of Kent, but there is only the smaller pathway. That is the only treatment that we can do with the supportive. So next video, we are going to discuss about the U wave and what is the other type of the J wave, ST elevations, calcium changes, and the potassium changes, and the digoxin toxicity. So this is what we'll be seeing in the part 2 of the condition. So please remember, for this FMG examination or the any other examination also, you can refer this complete video. So this will be giving the from the basics to the entire bradyarrhythmias and the tachyarrhythmias. And remember, you have to follow the concepts first instead of just memorizing the facts. So do the revision again and again, whatever you have read from the beginning. So please do join our Telegram and the WhatsApp group for the daily updates and the quiz and notes. For the videos, please do subscribe and share with your friends.